Hi, and welcome to AAHPO's American Armenian Health Professional Organization's TV Health Program again. This program is sponsored by Holy Name Medical Center. And tonight we have another interesting topic, which is a common topic among elderly people, both men and women, which is urinary incontinency. And today we're going to discuss about incontinency in women. And we have board-certified obstetric and gynecologist, Dr. Lucy Tomasian with us. Dr. Tomasian, welcome.
Thank you.
Today we are discussing the incontinence among women, which is very common after menopause especially. And we'd like to just tell our audience and to see what can we do for them. But let's talk about the incontinence. What type of incontinence do we have?
First thing I want to clarify is that it's not just elderly women, but all women, particularly even in the childbearing ages, can have urinary incontinence. But as for the types of urinary incontinence, the two most common types, the first is stress incontinence, and that's the type of incontinence that women have when they cough or sneeze or laugh. And the other common type of incontinence is urge incontinence, and that's what all those commercials for all those medications is about. They constantly feel the urge that they have to go because the bladder muscle is contracting when it shouldn't be contracting, and so they lose urine because of it.
Right.
There's other neurogenic conditions, but those happen more with people who have other
Let's
diseases.
take one of them at a time. Let's say stress incontinence. So the first symptoms will be that either they have urgency to go, or the symptom is more like they go frequently. It's not the urgency most, right? It's more frequency.
Well, pure stress incontinence, and some women have a mixture of both types.
Right.
Pure stress incontinence, actually there's no urge.
Right.
What it is that upon activity, women start noticing it when they're exercising, if they run or do a jumping jack, or do anything where they're lifting a heavy box, they may lose a small amount of urine.
Or coughing or
sneezing. Which
was the most common, I guess.
Yes, which during cold and flu season is very common.
Right.
Laughing is another one.
So this is stress incontinence.
That's stress
Let's talk about urge incontinence. What are the symptoms that they're coming with usually?
So they're the people who will come to you complaining mostly that they have to go all the time, that no matter what they do and how many times they go and how little they have when they actually empty their bladder, they're constantly feeling like they have to go to the bathroom.
And so the patient comes and says, the time that I feel that I have to urinate, I get up from my chair, I'm already urinating.
Yes.
So that's a kind of urge is there. They have to go, but they don't make it.
It is kind of like another category in and of itself, because actually doing things that you use to improve stress incontinence, which is improving the muscle tone in the pelvic floor, can actually help with that, because it's a matter of them being able to hold it to get to the bathroom, but they do tend to have more of an urgency as well.
What else besides these two can cause anatomical dysfunction can cause urinary incontinence for women? So when they come to your office, that you know that those things have to be ruled out.
So the first one is overflow incontinence. If there's some blockage or some inability to empty the bladder fully, this can happen if the urethra, the tube that carries the urine from the bladder to the outside of the body, if there's a closure in that, if there's a polyp in that, if there's some kind of anatomical structure that's preventing them from urinating. The bladder just gets fuller until it gets to a point where it increases so much in pressure that the patient can't pee, but every once in a while it'll gush out and it'll just spontaneously
empty. It's exactly
empty.
the same actually for men, because when they have prostate hypertrophy, when they enlarge prostate,
Correct.
It's exactly the same thing happens. It's a blockage.
It's a blockage.
Sometimes we have this anatomical abnormality. We have uterine prolapse, we have cystocele, we have rectocele. Let's start with uterine prolapse.
Uterine prolapse is a common occurrence. It can happen as a result of pregnancy and or delivery. Women who have normal deliveries and not C-sections have a higher risk of it, but though all women who've been pregnant are at risk. And it's basically a laxity of the pelvic floor muscles. And so the uterus, instead of staying up where it's supposed to be in between the bladder and the rectum, starts to come down.
Into the vagina.
Into the vagina, and can possibly even go further
and out. We use something called Pessaries at that time.
Pessaries are an option, and it's a form of a device. It's usually a silicone ring, and it has a little usually a little knob on it that will help replace the uterus, and that little knob can help replace the neck of the bladder and hold it up in place so that the patient doesn't have incontinence anymore. So the patient should not be surprised if they come to your office and suddenly you say, okay, I'm going to put this device in you. It's a simple pessary and how often it has to be changed? The pessary in and of itself, if the patient is willing to remove it and clean it and put it in herself, she just has to come in for checkups every 6 months or to a year. If the patient is unable to do that herself, she will come to the office every 3 months where we will remove it, clean it, and replace it.
So how about rectocele and cystocele?
Cystocele is basically a hernia of the bladder into the vagina, and it can again cause obstruction because it kind of kinks the path in which the urine comes out.
Right.
And so it can actually, in the same way that the uterus can come down and out, the bladder can come down and out as well.
Right.
And the same goes for the rectum. A rectocele is the rectum, so from the posterior.
Comes inside.
And that happens a lot. We see with people who've had vaginal deliveries and have had episiotomies, have had tears in that area that needed to be repaired, but the scar and damage in that area can cause a lot of laxity in the tissue.
And those could be the urinary incontinence. Obviously, their treatment is completely different. What we have this stress incontinence and the urge incontinence. Now, let's talk about the treatment a little bit. Let's start with stress incontinence.
Okay.
What do we have for stress incontinence?
If we start with the most conservative, the first line of treatment is always Kegel exercises.
Let's explain Kegel exercises to them.
Kegel exercises.
How am I going to do Kegel exercises? Tell me now.
So basically, the best way to figure out what the muscle is for the Kegel is to actually, while you're actually urinating, to try and stop the stream of urine.
Right.
That muscle that you use to stop yourself from urinating is the Kegel, is the muscle that we work out for Kegels. And so basically what you have to do is just exercise that muscle to strengthen it.
Hold that you're not going to urinate, let go, hold and let go, hold and let go.
Yes.
And nobody can know that you're doing it, so they can do it all the time as much as they want, right?
Exactly. And you do it for increasing lengths of time. So you'll hold it for 2 seconds first, and then 4 seconds, and then 6 seconds, and then you get it up to 10 seconds. And the more you do the exercise, the better, the stronger the muscle gets, and the less likely you are to leak urine.
The medication treatment could be different. So we have a test that we do urodynamics, obviously you do.
Yes.
So let's talk about the urodynamic study. What does it tell us?
So the basic methodology of the test is that I will slowly fill a patient's bladder in the office.
So they're in the office.
They're in the office. We put a catheter in, and then we put pressure monitors in different locations, and I can actually measure how much I'm filling the bladder, what the pressure inside the bladder is, what the pressure inside the patient's abdomen is, as a comparison to see what happens when the abdominal pressure increases, does the bladder pressure increase, and does the patient lose urine. And
then when patient feels actually it's full.
Yeah, right? And at what point the patient gets the first urge that the bladder is filling, the urge that they have to go to the bathroom, and the urge that they have to go to the bathroom right now or else they're going to have an accident.
What % of the patients that comes to your office that has urinary incontinence goes for surgery, you think?
It's a very low percentage that goes for surgery.
Which is good. So it means that they can get treated with medication or exercises that we recommend.
There's now pelvic floor therapy as well, so you can actually go to physical therapy for your pelvic floor muscles. There are core strengthening exercises, and so those have been very effective. But again, these are all things along with the Kegels that you have to keep doing. Even though you do the 6 weeks of therapy, what you learn in that time with that therapy, you have to continue on, or else it's just going to go back to the way it was. So there's that method. The Pessaries, we have incontinence Pessaries, which are also conservative management of them, of the urinary incontinence. And then there's the last step is surgery.
And obviously the main thing is that in ours, the patients come dehydrated, they don't drink enough water. We have other medical conditions. We say, drink water. So no, I cannot drink water because if I drink water, I'm going to the bathroom, so I'm going to urinate, so I don't drink. So what we advise them, they have to drink water. So what do we say to the patients? Drink your water and...
Not worry about they have to just go to the bathroom frequently.
Right, so frequent bathroom visiting is important.
Timing it regularly so they don't ever face the problem. And if they do have a legitimate concern with incontinence, to come and see a professional and get examined and figure out if there's anything else that we can do to prevent that from happening.
And there are so many medications that we can utilize, depends what type of urgent So,
Yeah.
or stress incontinence.
Yes,
That we have.
urge incontinence is treated with medications, with pills, and they used to be very difficult to take because they had some side effects. But now we have a lot of new medications that are really great for urge incontinence.
Sometimes patients saying that, oh doctor, I have the medication, so I take it when I go shopping, when I go visit my friends. Otherwise, I don't need it because I can go bathroom quickly at home. So that they take it usually when they go outside and they know they're going to be outside for a couple hours.
Okay.
Yes.
This type of medication is usually effective when you take it regularly. If they don't take it every day, when they need it, it's not going to work.
Right.
And they usually take 4 to 6 weeks to get to become fully effective in their bodies.
Right. So what time of the day is better for them to take? Let's say if they have the pill at night, should take it, or they should take it in the morning after eating breakfast.
Some of the older medications have 2 dosages, so they're taking it morning and night. We do have some extended release options, and taking it usually in the morning is a better time because that's usually when people remember to take their medications. Because once the day gets started.
But how about the patients that they usually complain, say, okay, daytime I might be okay, not bad, but at night I'm getting up every hour on the hour.
Then they can take it at night
So
if
those
they
people
want.
can be given at night.
They can be given at night, or those people may do better with doing the separated dose, to do a dose in the morning and a dose again at night, so that they get the benefit during the day when they're out, along with an added little extra before they go to bed.
That's excellent, Dr. Tomasian. Thank you for coming. Now it's time for this week's article, and it is about fish consumption and stroke. Fish is a major source of long-chain omega-3 polyunsaturated fatty acids. It contains the antioxidant selenium, and it is good source of an amino acid taurine, which is an important protein. Many randomized clinical trials have shown that fish oil supplementation can reduce the risk of stroke because it decreases blood pressure and blood triglycerides level, have a beneficial effect on inflammation, platelet aggregation, and improve blood vessel function. Findings from both United States and Swedish studies suggest that high consumption of broiled or baked lean fish, but not fried fish, may reduce the risk of stroke. In Swedish study, women who consumed 3 servings of lean fish a week had 33% lower risk of stroke compared to women who did not consume any fish. Therefore, to decrease the chance of stroke, you should eat fish 2 to 3 times a week and or take fish oil supplements. Good health is precious and priceless. Stay informed by visiting AAHPO's website, AAHPO.org. I'm Dr. Orhan Karadoprak. Until the next program, so long.